Good morning, everyone. It is such a pleasure to be here. I love being invited back to the EADV. Really value the opportunity to collaborate and connect with my European and international colleagues, so thank you so much for the kind invitation. I practice just outside of Boston, Massachusetts in the US, and for nearly 15 years, I'd say about 98% of my patients are hair loss patients. And I've been asked today to speak about Pseudopelade. These are my disclosures, none of which are particularly relevant to this talk. So when the email came in, you can imagine my excitement. Oh my goodness, EADV is going to be in Paris. I get to go to Paris, and I'm so excited, and I'm reading down the email, and oh, what is my topic going to be? Maybe JAK inhibitors, maybe something to do with scarring alopecia, and it says Pseudopelade. And admittedly, my reaction was something like this. Largely because, this is a hotly debated, not very well understood diagnosis. But I thought, well, we are going to be in Paris, and Pseudopelade was first described by a French dermatologist, Dr. Broch. And so I said, well, challenge accepted. So I'm going to do my best to walk you through what I've, in my deeper dive, learned about this diagnosis and give you my thoughts. So the objectives will be to understand the origins of the original term, discuss the clinical and histopathologic definitions of Pseudopelade, review the debate, and I did a small survey of hair loss specialists to get their take on Pseudopelade that I will share with you, as well as concluding with my personal thoughts on this diagnosis. So as I mentioned, in 1885, the French dermatologist, Dr. Broch, used the term initially Pseudopelade. And pelade in French is basically synonymous with alopecia areata, derived from the word pelage, meaning the fur, hair, or wool of a mammal. And Dr. Broch was very keen to put the prefix pseudo in front of pelade to indicate that while this condition can very much look like alopecia areata, it actually is a scarring form of alopecia areata that needs to be recognized. And while I was unable to obtain the original description that he put forth in his original writing about this, from other publications and literature, I was able to gather what Dr. Broch set out to be the classic definition of Pseudopelade. First, multiple discrete patches of hair loss, often described as skin-toned or white, most commonly affecting the vertex and parietal scalp. This vertex picture from a publication by Dr. Jerry Shapiro. Often with footprints in the snow appearance, so the scattered white patches throughout the scalp that evoke the appearance of footprints, sometimes with atrophy. And most importantly, minimal or no associated inflammation, which really differentiates it from inflammatory scarring hair loss conditions such as lichen planopilaris and discoid lupus. And importantly, it can be asymptomatic, very insidious, and slowly progressive. Now, for the demographics of Pseudopelade, it is most commonly seen in adults, usually in the 4th to 6th decades, and most of the cases have been reported in women, often with a 3-to-1 ratio. And while there's no ethnic or racial predilection, most of the reported cohorts in the literature do come from the European population. There are very few but reported pediatric cases of Pseudopelade, 1 in a 5-year-old girl, no family history, no preceding lesions or symptoms. Another report in 2 7-year-old brothers who had asthma and eczema, again, no preceding lesions or symptoms. And so in 1954, Dr. Robert Dagos, again, a French dermatologist who was responsible for a lot of dermatologic diseases, namely Dagos disease, looked at 109 cases and not only used, these were cases that were clinically diagnosed as Pseudopelade, and what he did is look at the histological findings in these cases. And of the 109 cases clinically diagnosed as Pseudopelade, He noted that 55% had features of other scarring alopecias, namely, particularly lichen planopilaris. And he said, maybe pseudopelade is its own thing, but the problem is that many end-stage scarring alopecias can look identical to it, and so this can create a lot of confusion. And he suggested using instead the term pseudopeladic state. That same year, the Spanish dermatologist, Dr. Jose Gay Prieto, who was head of the Spanish Dermatologic Association for years and also a founder of some of the most prominent schools for dermatology in Spain, said that throughout his entire clinical experience, he thinks he only really saw 34 true cases of scarring alopecia that matched the clinical description put forth by Dr. Brock, making up only 0.65% of the patients seen in their service. And he said in all cases, the alopecic surface was glistening white, right? No inflammation. But again, agreed with Dr. Dagos that because there can be so much confusion around this, maybe perhaps the term pseudopeladic state might be a better fit, because this way you avoid the confusion that can occur from later stage and end stage scarring alopecias that can result from lichen planopilaris or discoid lupus. In 1986, Dr. Braun Falco, who was chair of the Ludwig Maximilian Dermatology Department in Munich, Germany, put forth his clinical and histological criteria for pseudopelade of Brock listed here. And he looked at 41 scarring alopecia cases with histopathology and DIF, and he said, when you use very strict clinical criteria, right, for diagnosing pseudopelade, and you look at it histopathologically, there are no antecedent findings of discoid lupus or LPP, that you have to be very strict with your clinical criteria in order to make sure you have the right diagnosis. And he felt very strongly that this was a specific disease entity, that we should keep the word pseudopelade of Brock. And so others over the years looked at this. In 1993, 10 patients clinically diagnosed with pseudopelade, none of whom were reported to have histopathologic features that could distinguish it from lichen planopilaris. 1999, 25 patients clinically diagnosed with pseudopelade, 64% had biopsy findings similar to end-stage LPP. 2002, 36 patients clinically diagnosed with pseudopelade of Brock, 69% of which had features of LPP or discoid lupus on biopsy. And then in 2004, 12 patients with clinically diagnosed pseudopelade, 41% had features of LPP or DLE on biopsy. And so many of these authors said, it's nearly impossible to be able to distinguish it as its own entity, and argued more that it could be the end stage of other scarring alopecias. Much more recently, this was published in 2023, the use of elastic stains like Verhoeven-Giessen were reported to aid in the differential diagnosis of scarring alopecias, where pseudopelade of Brock has preserved or thickened elastic fibers, unlike lupus erythematosus or lichen planopilaris, which show loss or absence of elastic fibers. To my knowledge, there has not been a histopathologic correlation with clinical exam for a larger cohort, but this could be an interesting direction to also look at and delve into this deeper. So 140 years later, the debate remains. Is pseudopelade of Brock a distinct entity or just the final atrophic stage of several scarring alopecia disorders? As we discussed, some authors think it's a distinct entity, while others think it's just the end stage of lichen planopilaris and or discoid lupus. And some authors have said, let's get rid of this term completely, quote, abandoning the term altogether and replacing it with patchy scarring alopecia of unknown etiology would be a welcome improvement. So I said, what are my colleagues thinking about this? And so I sent out a survey to 20 international hair loss experts, 20 in total, average years in practice, 22.2 years, range between 12 and 45 years, and you can see the various regions of the world represented. And I asked the question, which of the following do you believe is true about pseudopelade of Brock? And you can see 18% thought it was an independent clinical entity, 29% felt it was a burnt-out phase of a different form of scarring alopecia, and 41% thought it was something else. And in the comments, by and large, those people who thought it was something else thought it's probably just LPP, right, a variant of LPP. And by the way, it didn't matter how many years in practice or where these people were seeing patients. There was no correlation between that and how they answered. So then importantly, well, okay, we might vary a little bit. A lot of people think this might be LPP or a variation of LPP. But what are we doing about treatment? If we think it's, and for those of you who think it's end stage, are we treating this? Or is it something that, we're just monitoring or just telling the patient there's nothing more to do? So I asked the question, to what degree do you agree with the statement that pseudopelade Brock is an active form of scarring alopecia and should be treated to prevent progression? And interestingly, 53% strongly or somewhat agreed that it should be treated. And 37% strongly or somewhat disagreed with the statement, 10% were neutral. But, 53%, I think, I could say, more than half, right, strongly or somewhat agreed with treating it. And so what do we know about the prognosis and the course of this condition? Well, it can be slowly progressive, and in some cases can remit over time, kind of spontaneously. In Braun-Falco's series, 60% of cases did progress until remitting, and on average, that time to spontaneously sort of stopping was about 8 years, while 40% of cases continue to progress. And if we think about, reported treatments, we do treat it very similarly to the way that we treat other forms of scarring alopecia, namely with oral, topical, or intralesional steroids, isotretinoin, hydroxychloroquine, mycophenolate mofetil, methotrexate, and more recently, sometimes use of JAK inhibitors. So what is my personal experience with Pseudopelade? It's rare, but I do think it's a distinct clinical entity. And the reason why I say this, I've seen, 1,200 or slightly more patients over the course of my career, and I've had 3 patients who I think have really had this. They've all been young. They've all come into me soon after noticing their hair loss, and despite me seeing them very early on in their disease process, there was absolutely no inflammation whatsoever on trichoscopy or clinical exam. You can see here the distribution, right? The parietal area, vertex area, and that footprint in the snow sort of appearance. And on a biopsy of these patients, there was no significant inflammation as well. There was evidence of scarring, there was loss of sebaceous glands, but no significant inflammation. And importantly, especially when we're thinking about a differential diagnosis like discoid lupus, there was no follicular plugging, there were no post-inflammatory pigment alteration, no violaceous erythema, perifollicular signs. And interestingly, all 3 of my patients had very, 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 some of the thickest hair I've ever seen, very thick, coarse, curly hair. And I only noticed this when I went back to report my cases for this talk, that actually of the 3 patients that I have, 2 have known celiac disease and 1 has a father with celiac disease. So I'm not really sure or clear on if that is a relevant association or not, but I thought it was sort of interesting. There are a lot of wheat proteins and shampoos and things like that that we use in the United States, so I'm gonna have to circle back to them and perhaps recommend that they avoid those in their hair care products out of an abundance of caution. So in conclusion, I think Pseudopelade of Brock is a rare but distinct entity, right? A post-inflammatory or clinically non-inflammatory scarring alopecia, likely a diagnosis of exclusion that can mimic alopecia areata and other end-stage forms of scarring alopecias. But because it can progress despite the lack of inflammation, I do believe that treatment should be recommended and these patients should be monitored. And if in doubt, the term pseudopeladic state, of course, can be used, or patchy scarring alopecia of unknown etiology could be considered. So with that, I will invite you to the 4th World Congress of Trichoscopy, which will be held in Rio, in Brazil, next fall. And merci beaucoup. Thank you so much for the invitation.
Thank you very much. Come please and join us. So we move on to the discussion, and before we answer questions provided online, are there any questions from the audience? I don't see any, so...
I have a question.
Sorry.
Thank you for a great...
Pseudopelade, I think the most important... From the edge of the alopecia. If you get it from the middle, you get an end-stage alopecia. But if you're looking for a cause, like lichen planopilaris, always make sure that you make a biopsy from the edge.
Yes.
This is a very good comment, because the edge is the active part of alopecia. So
yeah, and I just want to state, in the patients that I did present, those 3, I did biopsy at the edge early on in the disease, and there was not significant inflammation, but it's a very good point that if you're trying to distinguish, you need to take it from that area.
And also, I must add that the biopsy must be trichoscopy guided.
Yes.
Where we see the trichoscopy findings, there we take the biopsy. Please.
Okay, thank you for a great session. I have one question for Dr. Aslam. What is cicatricial pattern hair loss? Is it a variant of diffuse LPP or late stage of genetic alopecia, burnout, PD? What is it?
Okay, thank you for the questions. Cicatricial pattern hair loss is described in 2005. And normally the differentiation from the others that I mentioned here is the look-like female pattern, but there is no inflammatory reaction. There is no inflammation on perifollicular area, erythema, or hyperkeratosis. But to be honest, I didn't see in my clinical practice but the pencil eraser area of focal atresia is hallmark of the diseases. When you see that?
So maybe at a late stage AGA?
Maybe.
Thank you.
And I think there is a question, an online question about these topics. For example, the differentiation of FAPD and lichen planopilaris in diffuse pattern, it is meaning, is there a meaning or not? All of these diseases now we don't know. Maybe next studies will show us if it is the different diseases or the different time showing, we don't know. We don't know now. Maybe there's related to all of them.
I must say that Professor Georgios has made 2 questions regarding fibrosing alopecia in a pattern distribution. I would like to clarify that it is not my opinion that this entity is a scarring variant of androgenetic alopecia, so I don't have to provide evidence for this. However, as I mentioned in the end of my talk, I strongly believe that many of our patients with hair disorders have more than one disease, and there is significant overlap between these conditions. So if we call it associated diseases, maybe we can call it mixed phenotypes, whatever. Fibrosing alopecia in a pattern distribution make us think that may androgens have an impact also in scarring alopecia, as it happens in frontal fibrosing alopecia and fibrosing alopecia in a pattern distribution.
Yeah. I agree with you.
So, there is also a question To be honest, I don't remember that Professor Rudnicka mentioned that perifollicular scaling is not considered is not anymore considered a sign of disease activity. I could say that certainly it's not a sensitive sign because it takes time to develop and it takes time to go away. So from perifollicular scaling, we can only assess that it has been significant inflammation some weeks or months before. A very good clinical sign for lichen planariasis is itch, is pruritus, and the remission of itch after treatment is a very good sign of an effective management. And also, one question regarding if there is increased risk for autoimmune dermatosis in patients with neutrophilic alopecias. I would say that all patients with primary scarring alopecias, either lymphocytic or neutrophilic, have an increased risk for other autoimmune skin diseases.
I just want to add to that, if I could. We have an abstract that hopefully will present at AAD, where we looked at folliculitis decalvans patients versus many controls, over I think 5 million controls or something, and we saw statistically significant associations with folliculitis decalvans and non-alcoholic fatty liver disease, hypertension, obesity, and obstructive sleep apnea. So, just some of these metabolic things seem to be coming up a little bit more, so just something to share.
And we have one more question.
In terms of treatment, is it important to distinguish between FAPD and LPPDP? Because it's hard on clinical grounds, so...
I don't think so. I say we don't need to split hairs, and be picky, because basically we're treating inflammation, and most people, a lot of people with LPP, I think also have female pattern, so we're often treating that as well. I don't know that there's any dramatic differences in the way I treat.
Yeah.
I don't know about you.
Yeah.
In this case, there is no difference, but actually it is a common knowledge now that there are some scarring alopecias that have an alternating or an evoluting inflammatory infiltrate. And this is particularly true for folliculitis decalvans that may appear either with neutrophilic or with lymphocytic infiltrate. And the trichoscopic pattern goes accordingly. So it is very important before we decide treatment to see clinically and dermoscopically the patient and find out which is the predominating inflammatory cell at the moment for the patient. And as we know, there are differences in the efficacy of the different treatments, other targeting neutrophils like antibiotics, for example, and hydroxychloroquine is better for lymphocytic dermatosis. And for severe cases, always corticosteroids is the treatment, the rescue treatment.
But with the lymphocytic forms, because you described these two entities, FAPD and LPPDP, what is your treatment attempt? Because it's different to frontal fibrosing alopecia. So how do you treat these patients?
The first line treatment for LPP is hydroxychloroquine. And the second line could be isotretinoin. That has also some anti-inflammatory properties. In the case of frontal fibrosing alopecia, I favor dutasteride because clinical studies have shown that has superior results over all other treatments. And it sounds logical as frontal fibrosing alopecia is not only commonly associated with androgenetic alopecia, but also occurs in menopausal women, that we know that we have a change in androgen and estrogen ratio, and all these things support an hormonal approach for this disease.
Thank you, Dr. Aslam, for your lecture. It was very interesting. I believe, as you mentioned, there is a complex hair pattern, especially in females. But I think in the treatment of these complex hair disorders, when you treat both alopecia areata, androgenic alopecia, or frontal fibrosing, we need, and telogen effluvium, we need to concentrate on the metabolic causes. I always screen my patients with ferritin, vitamin D, albumin, and thyroid, because these are very important indices. So when you treat, I think the metabolic causes has to be optimized for all these patients.
Yes, thank you very much. So, is there any other question? Comments or whatever? Yes, please.
I actually have a question for all of you as a hair specialist. Pseudopelade, it was a fantastic lecture, by the way, thank you for it. What's your approach in the treatment? We know that it cannot regrow because it's scarring alopecia, but do you have yourself experience by stopping the condition, and is it successful? Because in my practice, I find it very difficult to manage the condition and to stop it and stop the progression of the condition. What's your experience on it?
So again, I have 3 patients. But what I can say is in those patients, because I'm worried that the spots could happen anywhere, I usually will have them on hydroxychloroquine.
Okay.
And because the spots are discrete, I feel like they're amenable to being measured. So I'll take the largest diameter of each lesion and sort of put it in my note and map it, and at each follow-up visit, monitor it. And if there's expansion, I'll often do every 3 months of intralesional steroids as well.
Okay.
And I've been, they've done well with that so far. We've halted things, but that's my approach. I don't think there's great data though on it. I don't know if you approach it in a different way.
What I would like to add is that, of course, there is no specific treatment for pseudopelade, but in all cases, as I mentioned before, in all cases of rapidly evolving alopecia, either scarring or most important, either not scarring or most importantly scarring, we must administer a course of oral corticosteroids about 0.5 to 1 milligram per kilogram over a period of 4 to 6 weeks. It is very important, and it is the best thing we can do.
And in your experience, Professor Koutoulis, when you stop the corticosteroid, actually, when do you add the hydroxychloroquine? When you stop the corticosteroid, or you add it simultaneously?
Usually, we use this treatment as a bridge to the treatment that would be affected lately, and it's a good also way to treat patients with alopecia areata that will take JAK inhibitors until we complete the whole procedure to get the JAKs. We can start them with a course of corticosteroids as an effective early treatment.
Okay, thank you so much.
Yes, please.
Hello, and I want to ask about apremilast. What do you think for LPP spectrum? Which patients do you prefer? I think it works